Hello, everyone, and welcome to today's webinar, Help Protect What Matters, Design and Performance of Alinity M Transplant Assays, CMV and EBV. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Scientific Affairs, Molecular Diagnostics at Abbott, and the program is sponsored by Global Scientific Affairs Molecular Diagnostics at Abbott. To learn more, visit molecular.abbott.com. Now, we encourage you to participate today by submitting any questions you might have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain your credits. I'd now like to welcome our speaker, Dr. Rick Nolte, Professor Emeritus in the Department of Pathology, Laboratory Medicine at the Medical University of South Carolina. Dr. Nolte, welcome. You may now begin your presentation, sir.
Well, welcome everyone to this webinar. We're going to talk about design and performance of Alinity M transplant assays for cytomegalovirus and Epstein-Barr virus. I'll go through the standard disclosures. Support for this program is provided by Abbott. I am speaking at the request of Abbott, and the Alinity CMV and EBV assays are CE marked and available for diagnostic use in CE marked regions only. So what are we going to try to cover today? We're going to do brief descriptions of diseases caused by both CMV and EBV. We're going to talk about the design of the Alinity M assays for these two viruses. We're going to talk a lot about the performance characteristics of the two assays. And finally, we're going to focus on some of the advantages that the Alinity M offers in terms of laboratory workflow. The disease overview portion of the talk, we'll start with CMV. CMV is a linear double-stranded DNA virus with a rather large genome, 235 kilobases, encoding approximately 165 genes. We know that the CMV DNA in plasma and blood is highly fragmented, so we don't have that large genome floating around free in the blood or serum. There's also, for a DNA virus, CMV has a high degree of genetic diversity, with frequent mutations arising when the virus is grown in cell culture and also within and between infected individuals. Individuals can be reinfected as a result of this genetic diversity. Individuals can be reinfected with different strains of CMV. CMV syndrome and disease. It's an important cause of morbidity and mortality in solid organ transplant recipients. The infection and disease typically occurs during the first 3 months after solid organ transplant. Its most common presentation is the so-called CMV syndrome, which typically manifests as fever, malaise, atypical lymphocytosis, leukopenia or neutropenia, thrombocytopenia, and elevated hepatic transaminases. End organ CMV disease usually, or most likely, is to occur in the transplanted allograft, but it also can affect other organs within a transplant recipient, the gastrointestinal tract, the lungs, the pneumonia, hepatitis, nephritis, myocarditis, pancreatitis, encephalitis, retinitis, and other organ systems less frequently. It's thought that CMV disease develops today in about 10% of patients undergoing hematopoietic stem cell transplant. And another important point is around preemptive and prophylactic use of high-potency antiviral drugs for CMV, like ganciclovir. They have been shown to result in increased risk of late CMV disease in both transplant populations. Let's move on to Epstein-Barr virus. It's a double-stranded DNA virus, just like CMV. It's one of the most common human-associated viral infections. It's estimated that 95% of the world's adult population has been infected by EBV. The primary infection with EBV is generally asymptomatic, but can lead to infectious mononucleosis in adolescents and young adults. Following the primary infection, the virus established a lifelong latency or persistent infection in B cells. The first time you get infected with EBV, you can transmit the virus for weeks, even before you have symptoms. Once the virus is in your body, it stays there in a latent, inactive state. And if the virus reactivates, you can potentially spread EBV to others, no matter how much time has passed since the initial infection. So the main problem with EBV in transplant recipients is a so-called post-transplant lymphoproliferative disease, PTLD for short. It's associated with EBV in 90% of cases and is a serious illness which can often occur in immunosuppressed transplant recipients. In fact, it's the most common malignancy that occurs in transplant recipients. The routes of transmission for CMV and EBV are very similar. They include, in transplant recipient, a positive donor, an organ from a positive donor. Vertical transmission can occur from mother to child in utero during delivery or by breast milk. CMV particularly can be transmitted through sexual contact with an infected partner, as well as can be EBV. Exposure to a variety of body fluids, blood products, saliva, and urine. So these represent the primary routes of transmission of both viruses. Manifestations of infection. So as we mentioned, once infected, the person carries the virus for life, which may be reactivated from time to time, usually with little effect on the individual. For the vast majority of people, CMV or EBV infection is not a serious problem unless the person's immune system is suppressed due to therapeutic drugs, a disease, an immunosuppressive disease, an immature immune system, particularly in congenital infections. And as we've already alluded to, infection with CMV and EBV is a major cause of disease and death in immunocompromised patients. Let's talk a little bit about the role of viral load monitoring in transplant patients for these two viruses. This is a sort of a generalization slide. It can be used for both CMV and EBV. Obviously, the donor and recipient are tested for their infection status for both viruses, typically via serology. Once that's been established, the transplant procedure is done, and then where viral load monitoring comes in is in the patient management post-transplantation. Looking a little closer at how that might work, this is a slide focused specifically on CMV monitoring and treatment in the solid organ transplant and the bone marrow transplant patient population. Typically in solid organ transplant programs, the antiviral drug is valganciclovir usually. It's administered for a defined period of time post-transplantation, typically from 3 to 12 months, depending upon the type of solid organ transplant. The schedule of monitoring also can depend upon the type of organ transplant. Lung transplant recipients, since they are among the most heavily immunosuppressed solid organ transplant population, typically will monitor their patients on a weekly basis for up to a year post-transplantation. Kidney transplantation, not so much routine monitoring, used more like a diagnostic test when a patient presents with a CMV syndrome or another potential manifestation of end organ disease. If we move on to the stem cell transplant population, really we're talking about preemptive therapy. The patients are most at risk for serious outcomes with CMV disease before the bone marrow totally engrafts, and that typically takes about 100 days. So during that 100 days post-transplantation, these patients are frequently monitored either once or twice a week, depending upon the program, for CMV viral load. And then late, as a guard against patients developing late CMV disease, they are monitored at regular intervals after that first 100 days. Let's talk a little bit about some of the challenges associated with viral load testing for CMV and EBV next. So the application and range of nucleic acid amplification tests used in the diagnosis and management of CMV varies significantly. Higher viral load correlates with increased risk for disease, but given the heterogeneity of nucleic acid-based systems, it is difficult to compare viral load measurements between different laboratories to develop uniform intervention thresholds or treatment strategies. So really, the particular clinical site and the various assays that are used across clinical sites need to be taken into account when thinking about developing thresholds for intervention. Quantitative nucleic acid results should be demonstrated to be linear in the clinically important range between the lower and upper limits of quantification. Precision of quantitative nucleic acid test results are such that the changes in value should be at least threefold, or 0.5 log, change to represent a biologically important change in viral replication. And when you get down to the lower end of the measurement range, down to around 1,000 international units per mil, the changes, the precision of the assays tends to be not as good. So changes may need to be greater than 5-fold or 0.7 logs to be considered significant. Yeah, continuing on with the challenges of nucleic acid testing in CMV, we all know that serology is not used in diagnosis of active CMV replication and disease post-transplantation. Quantitative nucleic acid amplification testing in blood is preferred for diagnosis and monitoring of CMV infection and disease. Qualitative results should be available optimally within 24 to 48 hours to optimize clinical decision-making. Both plasma and whole blood specimens are used for quantitative nucleic acid testing, and typically patients are monitored one to two times a week based on their risk of developing CMV disease. For highly sensitive assays in which the limit of quantitation is less than 200 international units per mil, multiple very low results might be sufficient to make a decision to stop therapy. So you could see how an assay with exquisite sensitivity, you may not require it to be not detected to measure a clinical response. Now, if we go to the hematopoietic stem cell patient population, you have to remember before the advent of viral load monitoring and preemptive therapy in this population, the leading cause of death post-bone marrow transplantation was actually CMV disease. So quantitative nucleic acid testing in the blood is preferred for diagnosis and monitoring of infection and disease. We already talked about the specimen type. My preference is for plasma, but some labs are still using whole blood. We already touched on this point. The first 100 days post-transplant is the time when the patients are at most risk for CMV disease, and it should be done at least on a weekly basis. Longer monitoring periods beyond that first 100 days is recommended in patients with acute or chronic graft versus host disease and those having experienced CMV reactivation, in patients having undergone mismatched transplant, cord blood, haploidentical bone marrow transplant or hematopoietic stem cell transplant, and in those on long-term effective prophylaxis, or in those displaying persistent immunodeficiency. With a viral load having the potential to double within 2 days or less, it promotes the frequent testing of these patients in anticipation of them eventually needing preemptive therapy. Let's move on to EBV and PTLD. So EBV viral load monitoring is done primarily as an early indicator of those patients who may develop post-transplant lymphoproliferative disorder. So prospective monitoring of EBV DNA is performed again by quantitative PCR. There's no consensus on the specimen type here. Many labs are still using whole blood. Our lab, in the last year and a half, switched from whole blood to plasma as a specimen type, and it was sort of a welcome change by the clinicians because they weren't bothered by us reporting persistent low levels of EBV DNA in whole blood. The calculated doubling time for EBV is as short as 56 hours, but longer than CMV. So this kind of gives you some basis for frequent monitoring in patients with rising EBV DNA levels in the blood. The frequency with which you may want to monitor these patients is dependent upon the donor and the recipient status. Those patients that receive a donor-positive organ that the recipient is negative are at highest risk for developing PTLD, and they should be monitored more frequently than those where the donor is negative and the recipient is negative. Weekly or twice weekly monitoring with the first year or at least first months after solid organ transplant is recommended. Okay, now we're going to dive into some of the specifics about the Alinity M, CMV, and EBV assays. We'll start first with the EBV assay design. Both tests are in vitro polymerase chain reactions test. Quantitative assays that can be used on both plasma and whole blood specimen types. They are intended for use as aid in diagnosis and management of both infections and transplant and other immunocompromised patients. The intended use in conjunction with clinical presentation and other laboratory markers as an indicator of initiation of therapy and for use as an aid in monitoring viral response to therapy, as measured by changes in viral load in either plasma or whole blood. Neither test is intended for use in screening blood products, tissue, or organ donors for either virus. Why choose the Alinity M assays over some of the other assays that might be on the market? Target selection and probe design, optimized nucleic acid extraction process, the calibration and data reduction strategies that the Alinity M assays use, and we'll get into that next. So both assays include target-specific probes for CMV and EBV, and an internal probe. The probes are single-stranded DNA fragments that have both a fluorescent reporter molecule and a dark hole quencher. In solution, in the absence of the specific target, the probes take a random coil configuration which keeps the quencher close to the reporter molecule. And it's important to note that both assays are dual target designs. The gene regions targeted in CMV are UL34 and UL80.5, and EBV GP350 and EBV NA1. This helps to prevent any genotype bias from introducing any genotype bias into the assays. What's shown in the lower panel of the slide is in the presence of the target, the probe binds and the reporter molecule is sufficiently separated from the quencher such that there is, after excitation, fluorescence emitted. And I might add that the dark color quenchers, since they have no intrinsic fluorescence, do tend to decrease the background signal in the assays. So, this is real-time PCR. So the fundamental process is something that I'm sure that you're all familiar with. The Abbott assays employ two calibrators, a low and a high calibrator, is indicated on the slide. They're done in triplicate, and the cycle number or cycle threshold for each calibrator is recorded. Then you test a patient sample, and its cycle number is compared to the standard curve created by calibrator A and calibrator B, and that's how you get the concentration in log international units per mil. Yeah, in addition, the data reduction software does a number of other things. This is a rather complicated slide. I'm going to try to give you the high-level view. So there's Abbott's data reduction software includes a max ratio method, which compares the fluorescent signal between cycles for each and every cycle. And it identifies a consistent point or very within or very near the exponential region of the PCR growth curve. Compared to other analytical techniques that generate only a cycle number and relative measures of amplification efficiency and curve shape. By using these values, the max ratio method can make highly reliable reactive, non-reactive determinations along with quantitative evaluation, particularly at the low end of the measurement range. So it's these other measures, the measurement of the cycle number, the relative measurements of amplification efficiency, and this curve shape that leads to the fractional cycle number that is particularly important in terms of being reliable, being able to assess the reaction efficiency, and really good at separating background noise from true amplification. Let's dive into the assay performance data next. We'll start with the CMV assay. So here's a look at the results that come off of the CMV assay, specimen type for both plasma and whole blood. You can see that the measurement range is 1.48 to 8 log international units per mil in plasma and 1.88 to 8 log international units per mil in whole blood. You can get a result of detected, but below the lower limit of quantification for both specimen types, and they're shown on the slide here, and also above the upper limit of quantification. You will get a result that is greater than what the upper limit of quantification is. And in both sample types, that's greater than 8 log international units per mil. The limits of detection, there are two ways that Abbott has established that through probit analysis and limiting dilution studies. And what you can see under the probit analysis column is the limit of detection determined by that analysis using one genotype, the GB1 genotype of CMV. The next column shows what the limit of detection was established via a panel of different genotypes of CMV, GB1, GB2, GB3, and GB4. And so the limit of detection set for the assay takes into account the different genotypes that might be encountered and is 30 international units per mil for plasma and 75 international units per mil for whole blood. This shows you plots of the linear range in both plasma and whole blood. As we talked about earlier, the linear range is not, it has a little higher lower limit of quantification than does the assay in plasma, 1 versus 1.48. But otherwise, the assay correlates very well. The target concentration and the measured concentration in both blood and plasma. If you look at the precision, this was done over, let's see, this is the total standard deviation. The precision was performed on a minimum of 3 instruments run by 3 operators using 3 reagent lots. With plasma, a minimum of 147 valid samples, and with undiluted plasma and dilution series of plasma with 147 valid samples at each point. So a similar sort of analysis was done with blood, and what you can see is a very good precision. The standard deviation was less than the total standard deviation was less than or equal to 0.19 log international per units per mil in plasma, and less than or equal to 0.35 log international units per milliliter. So quite good standard deviation. If you look at a clinical reproducibility study using actual clinical samples, the standard deviation still remains quite low. So this slide presents the results of comparing the Alinity M CMV assay results with the Abbott real-time CMV assay. And again, you can see quite a high correlation between the two methods. So the Alinity M CMV assay is highly correlated with the results from the M2000 real-time PCR assay. And the bias between the assays was quite small at 0.16 log international units per milliliter, and it was in favor, or a little higher, if you will, positive bias for the Alinity M CMV assay, but very close. This is looking at, previous slide was plasma, basically the same sort of results when you look at whole blood samples, and you compare the two Abbott assays on the two different platforms, and the mean bias, or the mean difference here was 0.32 log international units per mil for whole blood samples. So very similar to plasma. And then finally, in terms of looking at some of the performance of the Alinity M assay, it was compared with another FDA CE marked comparator assay. And the Alinity M CMV assay demonstrated a strong correlation and agreement with the comparator assay, and again a bias of 0.14 log international units per mil when the Alinity M assay was compared to another FDA cleared assay for the same purpose. So, summary of the Alinity M assay: dual target design offers redundancy of coverage and limits any genotype bias that might be associated with the assay. It is precise across a broad dynamic range. It's a sensitive assay that can detect CMV in both plasma or whole blood. And there is a strong correlation with the Abbott real-time PCR assay and the Abbott Alinity M assay with the FDA-approved comparator assays. Okay, I'm going to move on now to the assay, the EBV assay on the Alinity M platform. Same sort of data that I presented for the CMV. We're looking here now at the reportable results and how they, and interpretation of them for both plasma and whole blood. The dynamic range for this assay is 1.3 to 8.3 logs in plasma, 1.6, 8.3 logs in whole blood. You can get target not detected results, or you can get results that are detected but below or above the upper limit of quantification. Again, looking at the limits of detection, similar data done. The analysis was done two ways. When you look across the different genotypes of EBV, genotype 1 and genotype 2, the LOD is set at 20 international units per mil in plasma and 40 international units per mil in whole blood. Next slide. Again, linear range for both plasma and whole blood. As we mentioned earlier, 1.3 logs to 8.3 logs in plasma, 1.6 to 8.3 logs in whole blood. The linear range was also determined with EBV. This is genotype 2 with essentially the same results. Total standard deviation measured much in the same way as it was measured for cytomegalovirus. And you can see that the total standard deviation here in plasma is less than or equal to 0.026 log international units per mil and 0.28 log international units per mil in whole blood. So again, the cross comparison between the two Abbott platforms, the Alinity M and the M2000 platforms for measurement of EBV viral load. Again, you see an excellent correlation between the results and quite a nice agreement. The bias here was a little higher than it was with the CMV assay, 0.48 log international units per milliliter, but still within acceptable range. So this is the same data presented for whole blood. A little bit different, good correlation. The bias was different here. It was -1.13 log international units per mil for the Alinity M assay compared to the M2000 assay, but still quite a good agreement. So what can we say about, in summary, for the Alinity M EBV assay? Dual target design offers redundancy of coverage, just like it did in the CMV assay, and prevents, or at least limits the opportunity for genotype bias. It's precise across a broad dynamic range. It can be used to measure EBV in both plasma and whole blood. And there's a very good correlation between the Alinity M and the Abbott M2000 real-time PCR assay. So yes, let's talk a little bit about the Alinity and the ReadyFlex and how that improves workflow. Our lab has been a long-time user of the Abbott M2000 platform. We had the opportunity to implement the the Alinity M platform during the height of the COVID pandemic. So we really got a good feel for how the workflow can be improved from going from M2000 to the Alinity M platform. So the throughput is about 300 samples in 8 hours. we would need at least 3 M2000s to get to that same level of sample input. So that was certainly appreciated during the unprecedented volumes of testing that we were doing during COVID and continue to do. The turnaround time is much more rapid. That's why you can get greater throughput. The rapid turnaround time for all assays is 115 minutes to the first result. It also has tremendous flexibility. Although we used it as our primary workhorse during COVID, we have validated both the HIV and the hepatitis C assays on the Alinity M platform, and plan to move on to the transplant viruses once they gain FDA approval. But this ability to perform any test at any time is a remarkable advantage. And the stat prioritization, we utilize that often. We had critical patients with suspected SARS-CoV-2 application. But as a laboratory director, the batch mode analysis doesn't work all that well when you have a very demanding transplant population. And oftentimes we would get calls, although we would run the assay multiple times a week. On those days when we weren't offering the test, there would often be requests, special situations where we would have to alter our schedule to accommodate those special requests. That's really no problem with the Alinity M platform. So the combination of the increased throughput, the decreased analysis time, the opportunity to run any test at any time, and the availability of moving things to the front of the queue is really quite a welcomed improvement over the M2000 platform. So finally, I guess that brings me to the end. I'd like to acknowledge my colleague at Medical University of South Carolina, Dr. Julie Hirschhorn, who was the Associate Director of the lab when I was there, and she is now the Director of the lab, and also the entire MUSC Molecular Pathology Laboratory staff. And then at Abbott Molecular, Dr. Sarah Jones, Dominic Noelle, Francis Lennon, Lisa Cole, Mark Sasake, sorry, Mark, got the name out. And I'd also like to thank Danielle Lucic as well.
So thank you very much.
Thank you very much for your attention.
And thank you, Dr. Nolte, for that informative presentation. We will now start the live Q&A portion of the webinar. And if you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's get started. It looks like we already have some great questions coming in from our audience members. Dr. Nolte, as a lab manager, trying to consolidate diagnostic tests to run on fewer platforms, what assay features do you think are important for the CMV EBV viral load testing?
Yeah, that's a great question. We went through the last slide. I think highlighted a lot of the advantages for the Alinity M system, and we'll go through them again. The fact that the analysis time is greatly reduced is a big plus. The fact that multiple sample types for both EBV and CMV are acceptable, both whole blood and plasma. The fact that we have the stack capability of moving things to the front of the line, all I think are important in terms of thinking about a platform moving forward. And what drives my entire last decade of my career, I've been pushing for consolidation of molecular platforms in molecular pathology labs. I know many of you in the audience, as well as myself, have experienced a situation where you have a platform that may have one or two assays that are FDA cleared on it. The plan that Abbott has moving forward is quite impressive in terms of the number of assays they hope to develop in a relatively short period of time for the Alinity M. So the lab, our lab at MUSC had basically three platforms. The M2000 was the workhorse platform for all of our viral load assays. We had the hologic platform for the STIs, and then basically another platform for our orphan assays, those assays that weren't available on either one of the two systems. And that was the 3M system. So I hope that answers the question.
Thank you so much, Dr. Nolte. And as a follow-up, CMV and EBV do not have numerical thresholds, but rely on institution-specific parameters for patient monitoring and evaluation. What benchmarks would a new platform need to hit for you to be confident that the results fit into the evaluation scheme adopted by the institution, or to potentially change the existing threshold used by the institution? And this audience member says, for example, what outcome-based studies would you need?
Yeah, that's another really good question. And parallel testing with the old and the new assay would probably be the best way to get at that. And it's particularly, now there are several FDA cleared CMV assays, soon to be more. And even when you look between assays from different companies, it tends to be a wider or more difficult problem in terms of the bias that you might introduce by switching not only assays but assay platforms. And the best way to get at that, I wish, that's been one of the biggest problems in this area, particularly with EBV and CMV, is that laboratories a number of years ago many laboratories transitioned from laboratory developed tests to FDA cleared tests. And there often are wide differences when you make that leap. And so labs that are still using laboratory developed tests may have a harder time lining up the results between the FDA cleared test and the laboratory developed test. But the easiest way to get to that was going to be by doing parallel testing with the different assays for some period of time, and to establish what that difference in results will be when the switch is made, and then bring the clinician users of the assay into that discussion to help them interpret what the differences might be.
Thank you so much, Dr. Nolte. And I want to thank our audience members for these great questions coming in. We have time for a few more. This next audience member says, kind of connected to the VL threshold questions, QPCR assays have become more and more sensitive. Do you see that affecting patient management? For example, would you continue to treat a CMV positive patient with viral load results less than LOD?
Yeah, another good question, and one that really does need to be addressed. The sensitivity of the Abbott assays, the analytical sensitivity is quite good, and may be better than certainly some of the laboratory developed tests are deployed, and may be better than some of the other results that you would see on other IVD platforms. So that raises the question, what would you do if you're following patients that are on therapy? In my experience, using Abbott, running assays for CMV on the Abbott M2000 platform, typically we'd see dramatic declines in the viral load during the first 7 days of institution of therapy. And the standard of care in many places would be to treat until you get an undetectable result. That may be more difficult, right? If you're using an assay that has much lower limit of detection. And again, that's going to be something that will be challenging for laboratories as they move from one platform to another, and with a particular focus on doing parallel testing on those samples that have low or undetectable viral loads from patients on therapy.
Thank you so much. Our next question, you mentioned that you transitioned your EBV whole blood testing to plasma. Could you elaborate what prompted the sample type change? Question mark.
Well, blood has never been one of my favorite, whole blood has never been one of my favorite specimen types for any viral load assay. It doesn't store well. There's some difficulties. It presents some additional difficulties for nucleic acid extraction over plasma. And then you have this annoying problem with both viruses, both CMV and EBV, can remain latent in white blood cells. So if you are using whole blood, you're capturing, maybe capturing latently infected white blood cells, and then you find that patients have persistent low levels of both virus, could have persistent low levels of the virus. It's sort of a confounding thing for many clinicians, not knowing what to do with that, whether that needs to be specifically addressed in terms of a therapeutic intervention or whether it just should be ignored. Plasma has been shown, certainly for CMV and to a lesser extent with EMV, to be a better indicator. Finding and quantifying the virus in plasma, the cell-free component of the blood, is found to be in most studies a better indicator of active viral replication than finding the target in whole blood.
Thank you so much, Dr. Nolte. Now that WHO international standards are available for CMV and EBV, what additional information would be needed from a diagnostic perspective to be able to define a global threshold? Example, what parameters drive analytical performance of transplant assays, specifically CMV? Amplicon size and extraction efficiencies are critical when quantitation across different platforms are evaluated.
Yeah, that's another good question, and I think many of us in the molecular diagnostic community thought that having international standards available for many of the viruses for which we monitor viral loads, including EBV and CMV, would help narrow the difference between the different reagents that are available from manufacturers and the different laboratory developed tests that are out there. And they have helped. But there are many other components to go in to sort of that assay agreement that don't seem to be addressed by the use of international standards as calibrators. There are differences that can be introduced in the assays in terms of extraction efficiency, target selection is important. And so it was an important welcome first step in terms of assay alignment, if you will, but it hasn't addressed all of the issues out there. And in practice, we still do see some greater variations between assays that have all been calibrated against international standards than we might have expected.
Dr. Nolte, thank you so much for your time today and your presentation. Would you like to provide any closing remarks for our audience before we close today?
No, I just want to thank everybody for their attention. I hope this addressed many of your questions about not only who needs to be monitored for CMV and EBV, but all of your questions about the analytical and the clinical performance of the Abbott, CMV, and EBV assays.
Well, thank you again, Dr. Nolte, for your time and for your important research. And I also want to thank LabRoots and our sponsor, Scientific Affairs, Molecular Diagnostics at Abbott, for underwriting today's educational webcast. And before we go, I want to also thank our audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed by our speaker via contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Bye-bye.